Pleasant good evening to each and every one of you present here today. My name is Katie Hussein, and owing to its commonality and intricacies, today I will be presenting on vestibular schwannomas. So this slide relays these sections we will be exploring throughout this presentation. Cerebellopontine angle or CPA tumors are the most common neoplasms in the posterior fossa, accounting for 5 to 10% of intracranial tumors. Most CPA tumors are benign, with over 85% being vestibular schwannomas, which was previously known by terms now obsolete, such as acoustic neuromas, neurinomas of Verroque, and neurolamomas. They were first described in 1777 by Dutch anatomist Eduard Sandifort. Vestibular schwannomas are non-cancerous, well-encapsulated intracranial extraaxial tumors that arise from differentiated neoplastic Schwann cells, which, as we know, are derived from neural crest cells and myelinate and insulate peripheral nerves, aiding in both nerve conduction and axonal regeneration. This histologically benign tumor of the vestibulocochlear or 8th cranial nerve located in the CP angle usually arises from the inferior division, specifically the intracanicular segments of the vestibular portion of the 8th nerve, in more than 90% of cases at the junction of the glial Schwann cells or Obersteiner-Redlich zone classically. Less than 5% of cases arise from the cochlear component of the 8th cranial nerve. The WHO classifies schwannoma as a grade 1 benign tumor, and they are solitary in 90% of the cases, and multiple occurrences in the same patient should bring attention to syndromic associations, such as neurofibromatosis type 2, which we will look at later on, schwannomatosis, and Carney complex. So the Central Brain Tumor Registry of the United States shows that non-malignant nerve sheath tumors account for 8.6% of all central nervous system tumors reported, with no gender predominance, but a higher incidence in Caucasians over non-whites. Its incidence is 4.4 to 5.2 cases per 100,000 adults per year, and lesser in children and adolescents, being 0.44 cases per 100,000 per year, according to Ostrom et al. In 2019. This is in comparison to the incidence of malignant nerve sheath tumors being 0.03 cases per 100,000 per year. Schwannomas are the most common of all nerve sheath tumors in 89% of cases, with 60% of benign schwannomas being vestibular schwannomas. They usually affect persons between the ages of 50 to 60 years, with a median age at diagnosis of 56 years. And as we said, no sex or racial predilection is recognized. Traditionally, the estimated incidence of vestibular schwannomas was 1 per 100,000 persons. However, with the increasing usage of MRI technology, there's been an increase in the number of incidentally found vestibular schwannomas, with the incidence in the USA being 1.2 cases per 100,000. A retrospective study by Lin et al. In 2005, published in the Archives of Otolaryngology, head and neck, analyzed 46,000 MRI scans done for other reasons and identified 8 unsuspected vestibular schwannomas, giving an incidence of 0.02 or 2 in 10,000 persons. And in terms of the evidence of possible overestimates, a meta-analysis entitled The Global Incidence of Sporadic Vestibular Schwannoma by Marinelli et al. In 2022 identified 6 studies regarding national and international incidence rates in Denmark, Netherlands, Taiwan, and the United States. The incidence rate ranged from 3 to 5.2 per 100,000 persons, with Denmark having a number of 3.4 cases per 100,000, with a mean age of diagnosis at 60. In terms of the overestimates, they found one study by Marinelli et al. In 2022 identified a rate of even 20.6 per 100,000 persons per year in patients over age 70 years. So 90% of schwannomas are sporadic, those occurring in specific syndromes such as neurofibromatosis type 2, schwannomatosis, and Carney complex may have a possible genetic etiology, not only in the syndromic schwannoma, but in sporadic cases. NF type 2 accounts for 3% of the syndromic schwannomas, and schwannomatosis with 2%, and meningiomatosis with or without neurofibromatosis type 2 in 5%. Genetic studies show that neurofibromin 2 gene on chromosome 22 plays an essential role in sporadic and syndromic schwannoma development. NF2-related schwannomatosis occurs in individuals who have a defective tumor suppressor gene located on chromosome 22q12.2 and is inherited in an autosomal dominant pattern, presenting in late adolescence or early adulthood, and occasionally in the 5th to 7th decade of life. This NF2 gene encodes for the myelin protein or schwannomin, a cell membrane protein that acts as a tumor suppressor, and specific gene mutations cause its inactivation, thus preventing myelin protein formation. Myelin is involved with several receptors, including EGFR and signaling pathways with CD44, which is a cell surface receptor for hyaluronan, and plays a role in promoting contact-dependent inhibition of proliferation and suppressing tumor growth. There's increased myelin expression in Schwann cells, which prevents the hyaluronan from binding to the CD44 receptor, preventing tumor growth. Now, inactivation of both alleles of the NF2 gene is observed in most sporadic vestibular schwannomas. Bilateral vestibular schwannomas are a principal key feature of NF2, although there are other manifestations of the latter. Now, most patients diagnosed with vestibular schwannomas have no apparent risk factors. Exposure to high-dose ionizing radiation is the only definite environmental factor associated with an increased risk of developing it. Childhood exposure to low-dose radiation for benign conditions of the head and neck has been associated with an increased risk of its development. Evidence supporting a possible association between cellular telephone use, radio frequency fields, and brain tumors, including vestibular schwannomas, is mixed. A meta-analysis that included data from 22 case control studies concluded that there was a slight increase in risk associated with this use. But in those studies, the investigators were blinded to the participant being case or control. Furthermore, the risk appeared to be associated with a 10-year or longer induction period, and experimental studies suggest that increased oxidation levels with radiofrequency electromagnetic exposures may explain the association. Now, in many of the retrospective studies could have biases, example, recall bias, that could explain the positive findings. A prospective cohort study in 2022 by Schuss et al. Entitled Cellular Telephone Use and Risk of Brain Tumors, an update of the UK Million Woman Study, included over 775,000 females and 3,268 brain tumors, reported no increase in the incidence of brain tumors in cellular telephone users compared to non-users. And this is overall or by tumor subtype, including vestibular schwannomas, and this was over 14 years of follow-up. Similarly, the analyses considered changes in incidence rates over time, prevalence of mobile phone use, and latency period, providing new support for causal associations. Even so, in 2011, the WHO International Agency for Research on Cancer classified radiofrequency electromagnetic fields as group 2B, meaning possibly carcinogenic to humans. In terms of noise exposure, the data is conflicting as a risk factor, despite experimental studies supporting biologic plausibility. Most studies find a positive association have relied on self-reported measures of noise exposure, making it difficult to exclude recall bias as an alternative explanation. And in two population-based case control studies that used job exposure to assign noise levels, occupational exposure was not associated with an increased risk. Other studies, however, have found a positive association between vestibular schwannomas and self-reported exposure to loud noise in leisure activities without hearing protection. Now, in 2019, Cow et al. Did a systematic review and meta-analysis of 8 studies involving over 75,000 participants and found no significant relationship between overall noise exposure and vestibular schwannomas. But the subgroup analysis showed that leisure exposure over 5 years and continuous was associated with increased risk with odds ratios of 1.73. The incidence of vestibular schwannomas is increased in NF2 with a peak incidence around the 3rd decade of life, with bilateral vestibular schwannomas being a hallmark. Any individual less than 40 years of age with a unilateral vestibular schwannoma should be evaluated for NF2, as 10 to 25% present initially in this way. Cytologically, the vestibular schwannomas of NF2 are identical to sporadic cases. However, in NF2, the tumors form grape-like clusters that may infiltrate the nerve fibers, unlike most sporadic vestibular schwannomas, which displace the 8th nerve. There's also an 82% increased risk of developing a contralateral vestibular schwannoma if NF2 is diagnosed at the age below 18 years. Now, this is an example of NF2 in an axial fat-suppressed gadolinium-enhanced T1-weighted image of a 28-year-old male with bilateral vestibular schwannomas, showing the typical avid contrast enhancement. Here we have the coronal fat-suppressed gadolinium-enhanced T1-weighted image of the same patient, showing enhancing extraaxial tumors, likely nerve sheath tumors, in the foramen magnum. In terms of the histopathology, two histologic types of tissue have been identified in a biphasic pattern, which is shown in the micrograph on the right. Microscopically, they are composed of spindle-shaped cells with an abundant eosinophilic cytoplasm. Histology comprises of Antony A, or narrow elongated bipolar cells, or hypercellular in a palisading pattern, and Antony B fibers, which are loose reticulated of spongy texture with markedly reduced cellularity or hypercellular. Macroscopically, it appears globoid and encapsulated. Another characteristic histologic feature are rows of palisading nuclei called Verrier bodies. Also, immunohistochemical staining can distinguish schwannomas from meningiomas in that the former are immunoreactive to S100 antibody, while the latter are immunoreactive to epithelial membrane antibody. Histochemical staining for S100 is usually positive in both the benign and the rare malignant forms of this tumor, with malignant degeneration being extremely rare, with only 6 cases having been reported. There are no pathologic markers that predict recurrent or clinically aggressive behavior. Now, although rare, it's important to acknowledge the existence of primary malignant tumors of this cell type, as their histology is distinct from schwannomas. Malignant transformation may show malignant epithelioid cells, which occur even without neurofibromatosis. This table shows the histologic features relating to the 4 differing types of schwannomas: classic, cellular, plexiform, and melanotic. And you can peruse these at a later date. Schwannomas grow slowly and may exist for years without any symptom manifestation, with approximately 5-year delay between symptoms and diagnosis. 3 most common early symptoms or the clinical triad is hearing loss, which is insidious and progressive, tinnitus, which is high-pitched, unilateral, and non-pulsatile in 40% of cases, disequilibrium or imbalance in 60%, as true vertigo is uncommon. Most commonly present is unilateral asymmetrical sensorineural hearing loss at the time of diagnosis in more than 95%, and this is usually from compression and or stretching of the 8th cranial nerve and or cochlear damage from toxic factors secreted by the tumor. Other symptoms can include headaches, which are present in 50 to 60% of patients at the time of diagnosis. Less commonly, facial numbness occurring in 25% of patients, and facial nerve weakness or numbness due to trigeminal nerve involvement in tumors more than 2 cm. Trigeminal schwannoma causes numbness or pain in the trigeminal nerve distribution, and if the tumor is located at a specific root, that's V1, V2, or V3, pain and numbness are at the corresponding anatomical area of the face. Rarely, a patient will show the facial nerve palsy, and these symptoms are closely related to tumor size. Also, hypoesthesia in the cutaneous region behind the earpinnor or Hitzelberger sign due to irritation of the intermedius nerve can be present. There's also obstructive hydrocephalus due to the effacement of the 4th ventricle by tumors, along with brainstem compression, with corresponding lower cranial nerve dysfunction by larger tumors and even cerebellar symptoms. So for years, it was taken for granted that hearing loss was due to the compression or stretching of the 8th cranial nerve. However, recent evidence suggests the possible toxic factors secreted by the tumor causing cochlear damage. The hearing loss, as we said, is insidious and progressive and is most unlike that in Meniere's disease, which fluctuates. Sudden hearing loss may be a presenting symptom in 1 to 14% of patients with vestibular schwannomas, presumably due to an infarction of the acoustic nerve or acute occlusion of the cochlear artery, treatment options of which include steroids. 70% have a high frequency loss pattern, and word discrimination is usually affected, which is especially noticeable in telephone conversations. The tinnitus, as stated prior, is usually high-pitched. Unsteadiness manifests primarily as difficulty with balance, with true vertigo occurring in only less than 20% of cases, because these slow-growing tumors cause gradual rather than acute asymmetries in the vestibular function. In this setting, the central vestibular system can often compensate for the gradual loss of input from one side. In terms of trigeminal and facial nerve symptoms, these include otalgia, facial numbness and weakness, and taste changes due to the nervus intermedius impairment, as the tumor enlarges and compresses the fifth and seventh nerves. These symptoms usually don't occur until the tumor is more than 2 cm, highlighting an interesting paradox in that facial weakness is a rare late occurrence, even though the seventh nerve is almost always distorted early, whereas facial numbness occurs sooner once trigeminal compression occurs, often in the presence of normal facial movement, despite the fact that the fifth nerve is further. This may be due to the resiliency of the motor nerves related to the sensory nerves, xerophthalmia or dryness of the conjunctiva, paroxysmal lacrimation, and xerostomia can also be seen. Now, larger tumors can cause brainstem compression with ataxia, headache, nausea, vomiting, diplopia, cerebellar signs, and if unchecked, coma, respiratory depression, death, and lower cranial nerve dysfunction. Even palsies such as hoarseness, dysphagia, aspiration, and dysarthria can occur. Obstruction of the CSF circulation by larger tumors, usually more than 4 cm, can even produce hydrocephalus with increased intracranial pressures. Now, this table just shows a distribution of the presenting symptoms at the time of diagnosis. And as we said, the unilateral asymmetrical hearing loss is overwhelmingly the most common symptom, generally leading to diagnosis. And therefore, all patients with sudden sensorineural hearing loss should be imaged for workup for these vestibular schwannomas, even if they respond to steroids or their hearing spontaneously recovers. 66% of patients have no abnormal physical finding apart from hearing loss due to cranial nerve involvement. The Weber and Rene's test may be useful in suggesting asymmetric sensorineural hearing impairment, where the Weber test will lateralize to the uninvolved side, and if there's enough preserved hearing, the Rene's test will be positive. That is normal, or air conduction being more than bone conduction on both sides. Now, facial nerve dysfunction due to vestibular schwannomas is uncommon before treatment, and facial nerve function is commonly graded on the House and Brackman scale, which we will explore shortly. Vestibular involvement can cause nystagmus also, which could also be central or peripheral, and vestibular testing has limited utility in the evaluation of patients with vestibular schwannoma, one of which is abnormal electronystagmography, or ENGs, with caloric stimulation, which we'll also talk about a little later on. But when performed, a decrease or absent caloric response on the affected side may be seen. However, if the tumor is small, a normal response can be seen. This table summarizes the varying signs and symptoms in the vestibular schwannomas presentation and corresponding percentages of frequency. It should be noted that further neurologic examination may reveal other cranial nerve deficits and decreased or absent ipsilateral corneal reflex, facial twitching, hyperesthesia may occur as the cranial nerves 5 and 7 become affected, and other cranial nerve deficits are uncommon unless the tumor is large. The Romberg-Hallpike and other common office balance tests are typically normal. This is the House and Brackman's facial nerve grading system, which is widely used as an analytical tool developed to quantify facial function, characterized by the degree of facial paralysis, and provide reproducible information. It's simple, sensitive, accurate, and reliable, grading facial function in 6 steps, from 1 assigned to normal and 6 representing total or complete paralysis. Intermediate grades vary according to the function at rest and with efforts. Now, although the definitive diagnosis of vestibular schwannomas requires histologic confirmation, a confident clinical diagnosis can be made radiographically in most cases based on the characteristic appearance of an enhancing nodular tumor along with the 8 cranial nerve on high-resolution contrast-enhanced brain MRI. MRI and CT scans are among special studies to consider, but MRI is preferred. Recommended MRI sequences with level 3 evidence include the high-resolution T2 weighted and contrast-enhanced T1 weighted images with slice thickness less than 1.5 millimeters, in addition to the standard T1, T2 flare and DWI sequences in axial, coronal, and sagittal planes. Growth should be monitored with post-contrast 3D T1 magnetization, prepared rapid gradient echo MP range, or high T2 resolution, including the CIS sequence or Fiesta imaging, which may improve visualization of the tumor and the nerves. internal auditory canal protocol with millimeter sections through the internal auditory meatus can detect tumors as small as 1 to 2 millimeters in diameter on well-performed scans. An MRI usually shows an oval or round mass characteristically with an intermediate signal on intensity on T1 weighted images, strongly enhancing post-gadolinium, and a hyper-intense heterogeneous signal on T2 weighted images, with the lesion uniformly enhancing with gadolinium contrast. Large vestibular schwannomas that is more than 3 centimeters diameter may show cystic appearing areas on MRI or CT, and in actuality, these areas are usually solid. About 15% can contain cysts or adjacent trapped CSF cisterns may also give a cystic appearance. The tumor is graded using the Coos system, which is shown in the subsequent slide here. This is the Coos grading system, which is commonly used to describe vestibular schwannoma size and location on MRI. On the left, the arrows indicate the tumor, with grade 1 representing small intracornicular tumors confined to the IAC, and grade 4 representing those causing brainstem compression with cranial nerve displacement. Now, table 45.7 on the right relays the appropriate corresponding tumor volume for each Coos grade. Of note, a small subset of vestibular schwannomas are intralabyrinthine, meaning that they originate from the bony labyrinth, either the cochlea or the vestibule, rather than the internal auditory canal or CPA. And while there are a variety of classification systems for these, a multidisciplinary team group met during the 9th quadrennial conference on vestibular schwannomas and other CP angle lesions in Norway to establish an updated system for lesions, which can be known as the inner ear schwannoma classification. The Hanover tumor grading system refers to a classification system used specifically for grading vestibular schwannomas, primarily evaluating the extent of tumor growth within the internal auditory canal and its relationship to the brainstem, categorized into different levels spanning from T1, seen here, to T4B. Essentially, it assesses the severity of tumor progression based on its anatomical location and can help clinicians determine the most appropriate treatment strategy. A higher Hanover grade generally indicates a more complex surgical procedure and potentially a poorer prognosis due to the increased risk of neurological complications. This is just a table comparing the Coos and Hanover grading systems for vestibular schwannomas, and you can go through it in your own time. This slide relays the typical appearance of a vestibular schwannoma. On the left, we have an axial T1 weighted image of a 63-year-old male showing an iso-intense tumor in the right internal auditory meatus with extension into the cerebellopontine cistern without brainstem compression, and this is a Coos grade 3 or Hanover T3A. On the right, we have a fat-suppressed post-gadolinium T1 weighted image of the same patient showing an avid homogeneous contrast enhancement of the tumor, and you can note the acute angle formed by the posterior margin of the tumor and the petrous bone. This is a coronal T2 weighted image of a 39-year-old female showing the cisternal components of a vestibular schwannoma indicated by the arrow, and the T2 signal is heterogeneously hyperintense. Here we have an axial flare image of a 27-year-old male showing a slightly hyperintense left vestibular schwannoma extending from the fundus to just beyond the porus acousticus, widening the internal auditory canal, as well as increased cochlear signal as indicated by the arrow. On the left is an axial 3D Fiesta image in a 73-year-old female showing a Coos grade 2, displacing the adjacent 7th and 8th nerve complexes with widening of the IAC. And on the right, an axial 3D space image after the initial MRI showing development of cystic change in the medial component with progressive enlargement. This is also an axial 3D space image 5 years after the initial MRI showing marked enlargement of the cystic component with fluid-filled levels indicated by the arrows. There's also progressive widening of the IAC and now compression of the brainstem with distortion of the fourth ventricle without stenosis. This is an example of a small intrameatal vestibular schwannoma in a coronal 3D space image, demonstrating a 4 millimeter Coos grade 1 or Hanover T1 vestibular schwannoma in the inferior aspect of the internal auditory canal, adjacent to the fundus, shown by the arrow there. And these are axial and coronal fat-suppressed gadolinium-enhanced T1-weighted images demonstrating the avid contrast enhancement in the same lesion indicated by the red arrows shown. A lesion in such location could be missed if using the T2 sequence alone. However, it's easily detected following the administration of the contrast agent. So if MRI is contraindicated, then high-resolution CT scanning with or without IV contrast is the second choice imaging modality. Temporal bone CT for detailed bony anatomy if surgery is contemplated, and fine-cut CT scanning of the internal auditory canal with contrast can show widening of the IAC, whose normal diameter is 5 to 8 millimeters, and also rule out medium or large-sized tumors, but can't be relied upon to detect a tumor smaller than 1 to 1.5 cm. Many vestibular schwannomas can enlarge the ostium of the internal auditory canal, called trumpeting. However, 3 to 5% of vestibular schwannomas do not on CT. So thin cut temporal bone CT aids in operative planning with certain important features concerning the varying surgical approaches. For example, the middle fossa approach is used to assess the bony coverage of the geniculate ganglion to identify dehiscence. For the translabyrinthine approach, the extent of pneumatization of the mastoid and position of the sigmoid sinus. An anterior sinus with poorly pneumatized mastoids can indicate a tight space for this approach. And also, you can note the jugular bulb position. If high riding, it could indicate a tight space as well. For the retrosigmoid transmeatal approach, the location and thickness of the bony coverage over the posterior semicircular canal and vestibular aqueduct, and the extent of peritubular air cells and retrofacial air cells needs to be assessed in planning the approach and preventing CSF leak, which we will explore as a complication as well. So the table on the upper right really is the guidelines for otologic and audiologic screening for vestibular schwannomas, as audiometric testing should be obtained in all patients with a suspected vestibular schwannoma. Baseline studies are helpful for management or treatment decisions for feature comparison and to assess the contralateral air. Pure tone audiogram may be useful as a first-step screening test, assessing the functionality of hearing. Air conduction assesses the entire system, whilst bone conduction assesses the cochlea and proximally. And the pure tone average, or PTA, is a single numerical score that's an average of the thresholds of frequencies across the audio spectrum. And on hearing tests, an unexplained PTA difference from one ear to the other of more than 10 to 15 decibels is suspicious and should be investigated further. On the standard audiogram, a graph which shows the person's hearing sensitivity at different frequencies and intensities, the X's denote the left ear, and the O's denote the right ear. The x-axis shows the range of sound frequencies from low-pitched sounds at 125 Hz to high-pitched at 8,000, and the y-axis shows the level of sound power measured in decibels. Now, progressive unilateral asymmetric sensorineural hearing loss of high tones occur in more than 95% of vestibular schwannomas, even though this high-frequency hearing loss happens to be the most common type of hearing loss associated with age or with noise-induced sensorineural hearing loss. It's usually symmetrical. Now, an audiogram of vestibular schwannoma can show this asymmetric hearing loss, which is greater in one ear than the other. Increased pure tone average, a higher frequency of sound is needed to be heard. Increased speech threshold reception, or a higher level of speech is needed to be understood. And gradual high tone hearing loss, a loss of hearing worsens gradually at higher frequencies, as we stated before. And audiogram with unilateral sensorineural hearing loss is typically found with these schwannomas, as shown here on the extreme right, the diagram with the blue and red lines. So speech discrimination is useful in determining serviceability of hearing and prognostication for hearing preservation surgery. It's maintained in conductive hearing loss, moderately impaired in cochlear hearing loss, and worse with retrocochlear lesions. The open set word recognition score shown in table 45.4 on the right is a more sensitive measure of communication ability than the pure tone audiometry, and a variety of audiometric tests were developed in the mid-20th century in an attempt to identify patients with the increased likelihood of having a vestibular schwannoma. However, a lot of these audiometric exams are no longer used, and these are the ones shown here: the electronystagmography, vestibular evoked myogenic potential, and auditory brainstem responses. So there are many definitions of what constitutes serviceable hearing. Also, even non-serviceable hearing can offer some benefits. Now, if the word recognition score is good, which is more than 70%, but pure tone audiometry is poor, a hearing aid may provide significant benefits. Two commonly used scoring systems for hearing are shown here: the modified Gardner-Robinson system for graded hearing, shown in table 45.5, in which class 1 are patients that may use a phone on that side, and class 2, they can localize sounds. And then we have the American Academy of Otolaryngology, Head and Neck Surgery Foundation, AAOHNS, hearing classification system, shown in the table on below, 45.6, which incorporates both the PT and word recognition scores. So serviceable hearing can be considered in an AAO-HNS class A or B, or the 50-50 rule or Gardner-Robinson class 1 or 2, where the PTA threshold of less than 50 decibels and speech discrimination score of more than 50% is seen. Now, in a patient with good hearing in the contralateral ear, a speech discrimination score of less than 70% in the affected ear is not considered good hearing, whereas if the contralateral ear is totally deaf, a speech discrimination score of more than or equal to 50% can be useful. Now, in addition to the usual factors involved in the decision process with brain tumors, that is the patient's general medical condition, age, natural history, we have elements that are unique to vestibular schwannomas, and these include the chances of preserving the fifth and seventh nerve function and hearing, and also the presence of neurofibromatosis type 2. Now, however, in terms of the natural history of the tumor growth, the usual quoted range is about 1 to 10 millimeters per year, with an average of 1.4 millimeters per year, but this could be a bit variable. Tumors are strictly intracanicular. There was a 2006 study by Stangarap et al., published in the Journal of Otoneurology, which explored 552 vestibular schwannomas with a mean 3.6-year follow-up, and 230 were seen to be intrameatal, as well as 322 extrameatal extension, but only 70% of them grew outside the meatus. Now, for extrameatal tumors with extension into the CP angle, 30% grew more than 2 millimeters in the same study by Stangarap et al. Vestibular schwannomas that didn't grow in 5 years post-diagnosis didn't grow after that, and 6% actually decreased in size as per Bedison et al. Now, in terms of hearing function for untreated intracanicular vestibular schwannomas, and these are in AAO-HNS group A's, the rule of thumb for those presenting with serviceable hearing is that 75% retain this at 3 years, 60% at 5 years, and 40% at 10 years. 50% deteriorated to a lower class over 4.6 years, and after that 4.6 years of observation, the proportion of patients eligible for hearing preservation treatment, as determined by the word recognition score class 1, was reduced to 28%, that's seeing a 44% reduction, and in the AAO-HNS class A to 9%, so that was a 53% reduction. Now, the risk of losing hearing was not related to age, gender, vestibular schwannoma size, or tumor sublocalization, and hearing loss was positively correlated to the absolute volumetric tumor growth rates, in that tumors that eventually expand outside of the internal auditory canal have a faster rate and degree of hearing loss compared to those remaining in the canal. Now, the risk of losing hearing was significantly lower for patients with a WRS score of 100%, and over the 4.6 years of observation, 89% remained in WRS class 1 versus 43% patients. Only a small percent of those, 10%, had loss of word recognition score at diagnosis. Now, with tumors exceeding 15 millimeters in diameter, treatment complications increased significantly, with a lower chance for hearing preservation and increased incidence of cranial nerve 7 injury. Then we have cystic tumors, which may display sudden and dramatic growth. Also influencing management are serviceable hearing and hearing in the contralateral ear. Now, there are several means of managing vestibular schwannomas through varying pathways shown here, which we will each explore. The management options include the following: expectant management, in which symptoms and hearing with audiometrics are followed and tumor growth is monitored on serial MRI or CT imaging, with intervention being performed for progression. Growth patterns observed are shown here, little or no growth, which applies to most, 83% of vestibular schwannomas confined to the IAC or Coos grade 1, and to 30% extending to the cerebellopontine angle or Coos grade 2. Slow growth of about 2 millimeters per year, or rapid growth of more than equal to 10 millimeters per year, and a few actually shrink. This slide details the patients in whom an expectant or observational approach should be taken, along with the pre-op surveillance guidelines showing level 3 evidence regarding the MRI imaging. Observation involves monitoring diagnosed patients with serial imaging as well as audiologic evaluation without therapeutic intervention unless the growth occurs that necessitates therapy. So some of these level 3 guidelines state that the serial MRI should be obtained annually for 5 years, with a lengthening of the interval after if this is stable. Neurofibromatosis type 2 patients with vestibular schwannomas should be imaged more frequently initially and then annually once the rate of the tumor growth is known. Management options can also include radiation therapy. This is alone or in conjunction with surgery, and this involves external beam radiation therapy or stereotactic radiation. And this latter includes stereotactic radiosurgery and stereotactic radiotherapy. The stereotactic radiosurgery, or SRS, is as a single dose. There's little difference in radiographic control at different doses, and a single dose of less than 13 grays is recommended for hearing preservation and to minimize new onset or worsening cranial nerve deficits, and this is with level 3 evidence. SRT, however, is given in fractionated doses. So stereotactic radiotherapy uses radiation delivered to a precise point or series of points to maximize the amount of radiation delivered to the target tissues while minimizing the exposure of adjacent normal tissues with the goal to arrest tumor growth. Monitored with MRI scans post-treatment, this assesses for any changes in the tumor size, and possible indications for stereotactic radiotherapy for vestibular schwannomas are shown here. In terms of chemotherapy, these show preliminary promise for progressive neurofibromatosis type 2 related vestibular schwannomas with bevacizumab or Avastin, which is the anti-VEGF or vascular endothelial growth factor monoclonal antibody. And VEGF plays a major role in the development of brain tumors by binding to the VEGF R1 and R2 receptors on the vascular endothelial cells, and VEGF R1 was found to be overexpressed in vestibular schwannoma cells. However, a side effect of this was that hemorrhage occurs in about 7% due to vessel necrosis. The first case in which our patient survived surgical resection for vestibular schwannomas was in 1894, and the procedure was performed by British surgeon Sir Charles Ballant. And the 3 approaches for surgical management are shown here: retrosigmoid or suboccipital, which may be able to spare hearing; translabyrinthine, and its several variations, which sacrifices hearing but may be slightly better for sparing cranial nerve 7; and middle fossa approach, or extradural subtemporal, which is only for small lateral vestibular schwannomas. Now, the decision on the type of access depends on the tumor location, size, hearing status, facial nerve status, and a surgeon preference. Of note, there are no level 1 recommendations for most aspects of vestibular schwannoma management. Some recommendations here differ from the published guidelines quoted. For small, less than 50 millimeter tumor diameter with perfect hearing or WRS of 100%, one can observe radiographically utilizing the MRI or CT imaging in addition to serial hearing tests. This is referred to as the Wheaton scan. Treatment is recommended for more than 2 millimeter growth between studies using the following scan schedule shown here. Also, audiology evaluations are recommended. for hearing deterioration but no growth. The rationale being in that patients with small tumors and a normal WRS score, comparing the results of hearing preservation following surgery or SRS to the natural history, the conclusion being that established tumor growth should be the main determinant for treatment of these cases. Now, for small tumors with less than 50 millimeters with serviceable hearing, the management is controversial. Patients with serviceable hearing but a WRS score of less than 100% have 50% chance of preserving their serviceable hearing. And as we stated before, serviceable hearing was the class A or B of AAO, HNS, and 1 and 2 in Gardner-Robinson. And this is with either observation, SRS, or microsurgical resection. So observation is strongly recommended as the initial management. Hearing preservation rates better than 50% have been reported for both microsurgery and radiosurgery in very selected patients. These are those with smaller tumors locally located medially in the internal auditory canal and intact pre-op ABRs. Now, the decision to try to beat the natural history, which is 50% chance of hearing loss at 10 years, should be very individualized based on the tumor factors such as the size and location, as well as the patient factors stated here. And final management decisions are often dictated by non-medical reasons such as the patient perception, social situation, financial consideration, and support systems, etc. For medium-sized tumors, 15 to 25 millimeters in diameter, these should be treated, especially for young patients. Post-observation to establish growth is a valid option in older patients or those with significant medical comorbidities. The complication rate increases and facial outcome worsens with the increasing tumor size, as we stated before. And neurofibromatosis type 2 patients presents a unique challenge and should be evaluated individually. And in general, the success rate in the management of their tumors is lower owing to the higher cranial nerve deficits or higher recurrence rates. And therefore, early management is considered more favorable to achieve a good outcome. Now, for larger tumors, more than 25 millimeters in diameter, treatment is recommended. Microsurgical resection is favored due to reduce the mass effect and decompress the brainstem. And stereotactic radiosurgery is also useful in larger tumors for older patients and those with the significant comorbidities. For tumors more than 30 millimeters maximal posterior fossa dimension with brainstem compression, intraoperative monitoring of the trigeminal nerve and lower cranial nerves, that is 9-10, and use of the somatosensory evoked potentials or SSEPs is not obligatory but should be considered. For tumors more than 30 millimeters diameter with symptomatic hydrocephalus, an external ventricular drain can be pre or intraoperatively placed. And if there is unresolved hydrocephalus postoperatively, a ventricular peritoneal shunt should be placed. Larger tumors may be approached by a staged surgical approach to debulk the tumor and preserve facial nerve function, and a planned subtotal resection followed by radiation, or a planned subtotal resection, followed by radiation. And for these tumors more than 30 millimeters, such an approach seems to lead to improved results in terms of the facial nerve function postoperatively. Now, with regards to the comparison between microsurgery and radiosurgery in terms of the following: hearing preservation for patients with testable preoperative hearing, radiosurgery or stereotactic radiation appears to be better at preserving hearing than microsurgery, and these are for schwannomas, vestibular schwannomas, less than 2 cm up to 5 years post treatment. The chances of hearing preservation at 10 years is the same with SRS and MS, and the difference is minor for tumors less than 1 cm and very good preoperative hearing. The advantage of radiation is more pronounced for larger tumors and greater preoperative hearing loss. For SRS, overall at years 2, 5, and 10, 50 to 75%, 50 to 75%, and 25 to 50% of patients maintain their Gardner-Robinson hearing class, and hearing preservation appears to be related to the radiation dosage to the cochlea rather than to the tumor itself. For microsurgery, hearing preservation is significantly related to the tumor size and to the surgical team experience. Hearing preservation in Sami et al.'s 2006 series of 1,000 vestibular schwannomas improved from 24% in the first 200 cases to 49% in the later cases. It has also improved with the use of direct cochlear nerve monitoring compared to the ABR monitoring only, and hearing preservation in patients with class A small tumors and direct cochlear nerve monitoring was 91%. Now, with microsurgery, the durability of hearing preservation is also excellent, with only 15% of patients with class A hearing post-surgery and 33% of patients with class B hearing post-surgery slipping one class below at 5 years of follow-up. In terms of facial nerve preservation, this has been excellent with both microsurgery and radiosurgery. For microsurgery, we have 98.5% overall and 100% in tumors not touching the brainstem as per Sami et al. 2006 study. And stage resection has been advocated by some, as we stated before, especially in those with giant vestibular schwannomas, more than 40 to 45 millimeters. Regarding radiosurgery, 98% of patients and the incidence of facial neuropathy has significantly decreased since the dose was decreased to the 12 to 13 grays. As facial neuropathy was previously seen in those receiving 18 to 20 grays. Post-radiation cranial neuropathies usually appear around 6 to 18 months following the SRS, and more than 50% resolve within 3 to 6 months after the onset. And the recommendation, of course, is a course of steroids, corticosteroids. In terms of trigeminal neuropathy, this is a complication classically feared in large tumors, especially following SRS. And in SRS, a 7% incidence is seen mainly in patients receiving higher grade doses. No patients who received a dose of less than 13 grade developed this. For microsurgery, the post-op trigeminal neuropathy is not reported in most series. And then we have tumor control or local control rate. For microsurgery, tumor recurrence has been poorly studied with quoted rates varying between 0.5% at 6 years and 9.2%. For SRS, long-term data is lacking with currently favored doses of grays of 12 grays to the tumor margin. In 68 patients with sporadic vestibular schwannomas with 43 months median follow-up in a study in 2017 by Marston et al., intracanalicular vestibular schwannomas showed no growth after SRS in 9 patients. And in extracanalicular vestibular schwannomas, there was a 97% local control rate for those that grew at a rate of less than 2.5 millimeters per year before the SRS, versus 69% local control rate for those that grew more than 2.5 millimeters per year before SRS. Also, in this study published in the Journal of Neurosurgery, 10 to 18% of patients also showed pseudogrowth or swelling following SRS, defined as an enlargement of more than 2 millimeters in 6 months with later regression in the first half and stabilization to the new size in the second half. And this initial temporary enlargement of the tumor was seen to occur in 5% of patients, with up to 2% showing actual initial tumor growth. Post-SRS tumor recurrence requiring treatment at 5 years was 4%, and further treatment post-SRS should be postponed until there's evidence of sustained growth. Surgery should also be avoided during the interval from 6 to 18 months post-SRS, because this is the time of maximum damage from the radiation. Now, for patients with episodic vertigo or balance difficulties as the predominant symptom, they should undergo ENG or functional balance assessment, as they are susceptible to other causes of vertigo as well. Vertigo due to vestibular schwannomas is often self-limited, improves within 6 to 8 weeks to a reasonably tolerable level with no treatment or even vestibular rehabilitation. Residual dizziness and balance disturbances are common, whether SRS or microsurgery are used, but are typically less after microsurgery, with patients reporting improved intensity by any treatment other than observation. Now, post stereotactic radiosurgery, a minimum of 5 to 6 months and even up to 18 months may be required to produce beneficial effects. The symptoms are improved more rapidly, as we stated before, with microsurgery. Following microsurgery, the dizziness severity depends on the pre-op patient's vestibular function on the affected side. If the ipsilateral vestibular function is absent pre-op, then the patient will not suffer from the dizziness or nausea postoperatively. However, if it is intact, then the patient may be very dizzy and nauseated, especially within the first 24 hours postoperatively. With that being said, observation or wait and scan may be the best choice for 20% of these patients. And when treatment is desired, surgery is the best choice for most vestibular schwannomas producing vertigo. SRS may be the right choice for some, as in those in the elderly, more than 70 years, and the other indications shown here. The three basic surgical approaches will be touched on. For those with possibility of hearing preservation, the middle fossa approach, which gives poor access to the posterior fossa, and the retrosigmoid approach. And then we have the translabyrinthine approach in the non-hearing preserving. Now, excellent reports have been reported with each of these approaches, and the choice of approach is dictated by hearing salvageability and tumor size. For salvageable hearing, if the tumor is intracanalicular with no extension beyond a few millimeters into the posterior fossa or CPA, you use the middle fossa approach. Now, differences of opinion do exist regarding how much the tumor in the CPA can be removed via this approach, and some authors exclusively use the retrosigmoid approach for hearing preservation, even for these tumors with excellent results. If the tumor extends more than a few millimeters into the posterior fossa, then utilize the retrosigmoid approach. It's generally accepted that the cystinal part of the tumor is not well exposed by the middle fossa approach, especially regarding the ability to dissect the tumor of the nerves. Now, with regards to non-salvageable hearing, use either the translabyrinthine or retrosigmoid approach, and either one can be used irrespective of tumor size. Surgical team preference is also a deciding factor, and some influencing aspects are shown here. In young patients with no cerebral atrophy, they might favor the translab approach, or an anteriorly situated sigmoid sinus or high-riding jugular bulb restricting the working space, therefore might favor a retrosigmoid approach. Regarding the middle fossa approach, the indications are shown here for hearing preservation, laterally placed tumors or small ones less than 25 millimeters. And the pros of this approach allow drilling and exposure of the internal auditory canal all the way to the geniculate ganglion, which is good for laterally placed tumors, and it's basically an extradural subtemporal operation. The cons are potential damage to the temporal lobe at risk of seizures, and the facial nerve being the most superficial in this exposure, and therefore the surgeon risks possibility of damage. The technique for this procedure is shown here, and you can go through it at a later date. Regarding the translabyrinthine approach, which is often preferred by neurologists, pros and cons are shown here, with the former including early identification and preservation of cranial nerve 7 and a decreased risk to lower cranial nerves and cerebellum, and the latter including sacrificing hearing, extended operating time, and a higher risk of postoperative CSF leak. Again, the technique is shown here. So you can explore that because I believe we're running out of it of time. For the retrosigmoid approach, the pros are the possibility of hearing preservation, quick access to the tumor, and its familiarity to surgeons, which is often preferred. The approach is very versatile, with Sami et al. Performing all resections via this approach and achieving a significant amount of brain relaxation and improved exposure by using the sitting position, which also has associated complications. The cons of this approach, however, involve cerebellar retraction, which is not a problem for tumors less than 4 centimeters, provided the craniotomy is sufficiently lateral and the cisterna magna and CP angle cistern has been open. Also, headaches, and it's been suggested that headaches are more common following a retrosigmoid craniotomy versus a post-translab, and postulated mechanisms include in the trans lab, it's purely extradural drilling with no bone dust in the subarachnoid space, as well as a more anterior and skin incision in the trans lab approach, and less disruption of the suboccipital musculature, and also the greater occipital nerve. Again, the procedure is shown for this approach here, and table 45.12 on the right shows aids to locate the seventh cranial nerve seventh origin, which is particularly important within this approach. Now, post-operative complications can include cranial nerve and brainstem dysfunction. In terms of cranial nerve 7, if the eye closure is impaired due to cranial nerve 7 dysfunction, artificial tears should be used. And if the eye is also insensate from cranial nerve 5 impairment, it's at risk of exposure and trophic keratitis. An immediate ophthalmology consult is indicated for emergency torsophrony. Now, vestibular dysfunction is also common post-op with nausea and vomiting due to this being common, and the combination of 9th, 10th, and 12th nerve dysfunction creates swallowing difficulties and also aspiration risk. Brainstem dysfunction may also occur from dissection of the tumor of the brainstem, producing ataxia and contralateral paresthesias. Although there may be improvement once present, there's often some permanent residual. Also, we have risks as CSF fistula, which may develop through the skin, CSF arteria through a ruptured tympanic membrane or via the eustachian tube, and then either through the nose or to the back of the throat. Most leaks are usually diagnosed within the first week of surgery, but can also present later on, and they appear to be more common with more lateral unroofing of the internal auditory canal. Meningitis complicates a CSF leak in about 5 to 25% of cases and usually develops within days of the onset of the leak. Hydrocephalus may also promote the development of a CSF fistula. Now, rhinorrhea may occur through any of the following routes circled in the diagram shown on the right, figure 45.11, with number 1 being via the apical cells to the tympanic cavity or the eustachian tube, which is the most common pathway. Table 45.13 on the right shows the stats of cranial nerve 7 and 8 preservation following suboccipital removal of vestibular schwannomas in several combined groups of patients. Post-radiation cranial neuropathies, which can generally appear in 18 months following SRS. More than half of these can resolve within 3 to 6 months after onset, and recommendation is treatments with a course of corticosteroids. Now, grades 1 to 3 House and Brackman are associated with acceptable facial nerve function. Although total tumor excision is usually the goal of the surgery, facial nerve preservation must take precedence over the degree of resection. Near total resection, which is when a very small sliver of tumor is left on the facial nerve, or subtotal resection are all excellent options if the tumor is tightly adherent to the facial nerve or brainstem, and both have excellent long-term tumor control rates with either observation or post-op radiation. Facial nerve preservation is related to the tumor size, of course, and with the use of modern facial nerve monitoring techniques, the anatomical integrity of the facial nerve can be achieved in more than 90% for even very large tumors, and in close to 99% in medium-sized tumors, as per Sami et al. Study in 2010. In cases where the nerve is so flattened that the tumor has to be left over the nerve to preserve its anatomical integrity, functional outcome of the facial nerve is nevertheless lower, especially with the larger tumors. Excellent outcome was only achieved in 75% of patients with large tumors and 91% of patients with medium-sized tumors. And for SRS, for tumors less than 3 centimeters in diameter, the modern dose SRS dosimetry of 12 grays and in patients with serviceable hearing, and 13 grays for patients with non-serviceable hearing, the incidence of new facial nerve weakness was seen to be 4%, as per Pollock et al. In a 2006 study. Now, preservation of hearing is critically dependent on the tumor size, with little chance of preservation in tumors more than 1 to 1.5 centimeters diameter, as hearing loss has been correlated with an increase in tumor size. And the chances of preserving the hearing may possibly be improved by the intraoperative BAER monitoring. Hearing may rarely be improved postoperatively, and vestibular nerve function is rarely normal post-op. And attempts at vestibular sparing surgery have shown no better results than surgery not specifically addressing the issue. Most patients with unilateral loss of the vestibular nerve function will learn to compensate to a significant degree with input from the contralateral side if normal. We also have postoperative trigeminal nerve symptoms, which can occur transiently in 22% and permanently in 11% following microsurgery, and these are similar to results of SRS, and new facial numbness occurring in 2% with stereotactic radiotherapy. In terms of post-operative recurrence, it's highly dependent on the extent of tumor removal, and it can develop in tumors that were apparently totally removed, or even when subtotal resection was performed, and this can even occur many years post-treatment. Tumor progression rate following subtotal resection is about 20%, and all patients should have follow-up imaging. In an older series by Pollock et al. With up to 15 years follow-up, the local control rate after total resection was 94%, but more recent series with MRI follow-ups indicate recurrence rates of 7 to 11% with 3 to 16 years follow-up. And level 3 evidence suggests that SRS is safe and effective to retreat patients with vestibular schwannoma progression after initial SRS, and that the patient should be informed that there's a minimal risk of malignant transformation of these tumors. Two separate large single-center retrospective studies estimated the malignant transformation rate of 0.3% after SRS. But still, SRS offers a safe and effective long-term management strategy for residual and retained vestibular schwannomas. ERBT may improve the local control rates in incompletely resected tumors, shown in table 45.14. Now, unfortunately, many patients with vestibular schwannomas lose some or all of their hearing either from the tumor or intervention to remove or control the same, and this loss can be immediate or progressive over years. Loss of the hearing in one ear can pose 3 of the major problems shown here, and while the focus tends to be on the diagnosis and treatments of the schwannomas, options for rehabilitation of hearing deficits are slowly increasing. If the surgery is planned, pre-op discussions of these options are important, as the titanium screws and cochlear implants could be placed at the time of the surgery, even when hearing is gone or expected to be lost. And then rehabilitation can start much earlier in the post-op course without requiring a second operation. Therapies range from supportive compensatory strategies to hearing aids and implantable devices. Individuals can function with only one hearing aid, so positioning themselves so that the good ear is always towards the action or conversation, even in quiet settings, can minimize the impact of having only one hearing aid. Also, we have the use of hearing aids, if any serviceable hearing is left, or to consider a CROS, or contralateral routing of signal hearing aid, if it is not. And the mechanism of action of the CROS is shown here, so you can read up on that. Then we also have cochlear implants, which are devices where an electrode ray is threaded into the cochlea to stimulate the auditory nerve, directly requiring the auditory nerve to be intact. And this is the case for patients undergoing observation for growth, those who've had radiation, and post-surgical patients in whom the auditory nerve was left intact, no matter what the approach was used. And then we have brainstem implants, which have been available for many years with the electrodes placed next to the cochlear nucleus to stimulate the area directly and bypass the inner ear and cochlear nerve directly. The success is limited due to the number of electrodes being used is small, and contact of the electrodes with the cochlear nucleus may be suboptimal, and they're usually done when the patient has loss of hearing in both ears or no auditory nerve to stimulate. Now, this is just a slide relaying a recent paper by Bin Alama et al., published in the CNS Neurosurgery Journal in January 2025, entitled The Vestibular Schwannoma Coos Grade 1 International Study of Active Surveillance versus Stereotactic Radiosurgery, or VISUS K1 study. And it was a multi-center study involving Turkey, US, India, Dominican Republic, retrospectively analyzing 142 patients with Coos Grade 1 vestibular schwannomas, who were divided into two arms, the SRS group and the observational group, with a median follow-up of 36 months. And it showed that SRS significantly enhanced tumor control compared with observation, with 100% control rates at 5 and 8-year marks in the SRS group versus the observation group for the same time intervals. And the p-value was less than 0.001. Preservation of serviceable hearing outcomes between the two groups showed no significant difference at 5 and 8 years, ensuring a comparable quality of auditory function. And furthermore, SRS was associated with a reduced likelihood of tinnitus, vestibular dysfunction, and overall cranial nerve dysfunction at last follow-up. So it concluded that SRS management of patients with Coos Grade 1 vestibular schwannomas was associated with a superior tumor control, reduced odds for cranial nerve dysfunction, while not compromising hearing preservation compared with observation. And these findings could support the safety and efficacy of SRS as a primary care approach for this patient population. This slide just releases a summary of the pre-op and post-op radiological guidelines, specifically MRI associated with vestibular schwannomas, and can be reviewed at your leisure. This is an easy-to-read flowchart describing the management of unilateral sporadic vestibular schwannomas in adults according to the Coos grading. And this slide provides a summary of the guidelines for surgical management of vestibular schwannomas, as well as pre-op evaluation in preparation for surgery. These are my references. Thank you.